Hello, hello, and thank you for joining us here with your favorite Tuesday night show, and that is How with Dr. Gigi, or Auntie Gigi, as I like to call her. So tonight, we're going to be talking about one of the potential dangers that can happen when somebody is suffering with diabetes. And so when we talk about diabetes, or the sugar, as we sometimes call it in the community, is we tend to focus on our blood sugar levels. We talk about insulin, and you might hear, diabetic neuropathy, and I forget when you lose the feeling in your lower extremities. But what we don't talk about is what we're going to be talking about tonight, and that is uh, kidney disease, chronic kidney disease being a result of diabetes. And so we've got a special guest that's going to be joining us here to talk about his journey from diabetes to chronic kidney disease to being an advocate, and to we're going to talk about some solutions as well tonight. But first, a little housekeeping. If you know somebody that needs this information, make sure you tag them or share this show. Also, let us know where you're watching from. We always like to see where people are watching from all over the world. We've had people watching us from as far away as Sri Lanka and South Africa and Great Britain. So we love to see people watching us from all over the world. And finally, ask questions. So put your questions in the comment section, especially if you know someone or if you are a diabetic. Please put those questions in the comment section, because we want to get those questions answered so you do not suffer the same situation that we had with our guest tonight. But before we get to our guest, I've always got to say, hello, Dr. Gigi.
And hello, Mr. Dean. It's so good to see you. Happy to be here this evening to talk about a really important topic. And before we bring our special guest tonight to talk about his own experience living with diabetes, I just want to give people a background, because there's a lot of misconception out there, and I hope that we can clarify things. There are two types of diabetes. The
Right.
type that's type 1, which often occurs in children, and basically that is a result of a virus attacking the cells of the pancreas that make insulin.
Okay.
When you have type 1 diabetes, you must take insulin. You can't, nothing else will work, because your body no longer produces insulin. Now, there is hope, because there are some transplant technologies that are becoming easier to do. But, a child, I have a cousin who was born healthy, all that. And then I want to say at the age of 18 months, a virus attacked his pancreatic islet cells. And then he's been on insulin ever since. He's now, I want to say, 45, married with kids. But that's type 1. Type 2 is the one that we actually have control over. And type 2 is the one that actually can run in families. Sometimes people think that because a child got type 1 that it's something genetic. No, it's actually type 2. Not that genes can't play a role, but type 2 is the one that's predominantly genetic. So how does that occur? Well, we're making insulin, but as we get chunkier, especially have more weight in our belly area, the body becomes resistant to the insulin that we do make. So that's why we end up having to take medications. We start off taking oral medicines, and then we may need to switch to insulin. But now there are other medications that are not insulin that actually can help to preserve kidney function and even protect our heart. There are many new treatments out there, and now there are even once a week injections that make it a lot easier for people to get their diabetes under control. So why does diabetes have so many complications? Well, let's think of the blood vessels. Of course, we've got the large blood vessel that comes off of our heart called the aorta, and then the blood vessels that supply our arms, our legs, our brain, kidneys, and the rest of our vital organs. Well, as the blood vessels get smaller and smaller, going to, the eyes, the heart, the kidneys, the feet, what happens is that the glucose actually interferes with normal functioning of those blood vessels. So when your glucose is elevated, those small blood vessels get impacted. So now you can understand why, if you don't have diabetes that's well controlled, we now know that it's actually a risk factor for dementia because of the blood vessels that supply the brain. We know it can affect the eyes and can lead to blindness. We know it can affect the heart and lead to heart disease. We know it can affect the liver and help to accelerate fatty liver and even cirrhosis. We know that it can affect the kidneys, which is what we're going to be talking about today, but
Mm.
also the skin and the blood vessels. So, one of the very dreaded complications, thankfully it's not as common today because there are so many better treatments, is when people develop gangrene in their, let's say, toe or foot because there's not enough of a blood supply that's going. And so what
Right.
can happen initially, that diabetic neuropathy,
Yep.
people lose their feeling. And let's say they step on a, stub their toe, they may not even know that they've injured their toe, and the healing is decreased because of the diabetes. And the next thing that you know, you've got gangrene, and you may need to amputate. But all of those are preventable. There's good news, and everything is preventable. Number one, the best way to treat diabetes is to prevent it in the first place.
Right.
And that is by trying to keep your weight down. And I'm chunky, and sometimes people think that they have to be rail thin to have the benefits of losing weight. You don't have to be. Actually, one of the things that's true about diabetes is that exercise, like brisk walking, sensitizes the insulin. It makes your insulin that your body's producing, your body's more sensitive to it. And so losing, depending on how, high your glucose is, of course, but having a modest weight loss can actually have a big impact on your glucose. And
Mm.
now we're actually using medications to prevent diabetes from even occurring in the first place. So for somebody like me, I've got a family history of diabetes. I'm chunky. I'm getting older, right? So I actually am taking a medicine, metformin, which is used to treat diabetes, but in my case, it's to prevent me from developing diabetes. Does that make sense?
Yes, and it's funny. That was one of the questions that was asked already early here in the show from Jessica, and she was asking. She said she's pre-diabetic and she's got high blood pressure, along with meds and healthy diet. Is there a chance at 29 to make a change? And so I was like, absolutely, especially with her being so young. That there are natural ways to lower your blood sugar, and being pre-diabetic can keep, if you could do those things, make those changes with exercise, eating healthy foods that are naturally lowering your blood sugar, like cinnamon and other items, that you can get out of that pre-diabetic status. You can help lower and then just losing weight will also help lower your blood pressure. And so if you're overweight, if not, then there's other ways to lower that blood pressure as well. So absolutely, there's always help. I mean, don't.
Can I tell you what I have learned over the years of being a doctor is that our bodies are actually very forgiving.
Mhm.
And I know that the show before this one was veganish. Probably one of the best kinds of diets are foods that are fruits and vegetables and plant-based diets. And they're good for everything, including prevention of diabetes, or for people who have diabetes to go
Mhm.
on a plant-based diet, whole grains, minimizing red meat, if not eliminating it totally. But really, where we get into trouble with diabetes is those processed foods, right? Whether
Right.
they're the cookies or the chips, or when you eat out, all that kind of stuff. That's where we get into a problem. So, and remember, small changes can reap big benefits. If you're eating at McDonald's 5 days a week, well, you know what? Cutting to 3 times a week may be the way that you start.
Right.
And then two, and then one, and then making it an occasional treat. So I don't like to kind of, get on people. No, changing behavior is tough,
Yes.
especially when it comes to eating, because it's not something that you can just stop doing.
Right.
And probably like a lot of folks, I know that when I'm under stress, what do? Some of us comfort ourselves with food. So,
Well, the pandemic has been extremely stressful. You think about what's been happening, especially in Black communities, communities of color, communities where people have lower income. And so they are frontline workers that had to go back to work, had to continue to put themselves in harm's way, healthcare workers that are continuously in harm's way. So the pandemic has increased our overall stress level as a country. And being indoors, isolated, stressed, it's suffice to say, unhealthy eating has been on the rise. There also has been a rise in non-alcoholic fatty liver disease, which can be very damaging to your liver as the filter of your body. You want your liver to be as healthy as possible. And then there's also been a rise of high blood pressure and then mental illness. And so there's all these other kind of things that come from as a result. But so we've got to be really, really intentional. That's an important word. We have to be intentional about what we eat and how we eat in order so we don't have these medical issues that continue to rise or even happen in our own lives.
Absolutely. And I'm so excited to hear from our special guest this evening because he's going to walk us through his journey with diabetes and how that's impacted his life. So I'll let you introduce the special guest, Mr. Dean.
Well, this is Dr. Patrick OG. He's also OG. I like that. He's also a pastor. And, he was recommended to us because we talk about diabetes a lot. We've done our Operation Life series on diabetes. And as African Americans, you cannot talk about health and wellness without talking about diabetes. But what we haven't been talking about is the connection to chronic liver disease, because people say, oh, it's diabetes. It's the sugar, it's bloodstream. People know about amputations and maybe was it glaucoma, they know about those things associated with diabetes, but they don't talk about chronic liver disease. And so when they came across my desk and said, no, you got to talk this and we got to bring that connection, I reached out to him and said, Dr. G, would you want to come on and tell your story? And he was so receptive and said, yes. And then we had a great conversation prior to this. And so I just want to say welcome to the program, Dr. G. And really, really thank you for coming on and kind of giving people some cautionary tale about what could happen if we're not paying attention to everything that's going on with diabetes. And you were taking care of your diabetes, weren't you?
Oh, yes. Yes. And thank you for having me on it. It's an honor to be here, especially when I'm with a doctor whose name is Gigi. So I'm not mad today.
Well,
I feel right at home now.
Hey, look, so some of my nicknames are G or Dr.
That's
G,
right.
Dr. J, all kinds of stuff. So yeah, I feel you.
Yeah. So I'm right at home.
Dr. K in the comment section. So guys, please put your questions in there because Dr. K is in the comment section answering questions. So thank you for that. Dr. K, Special K, we know y'all met her a couple of weeks ago with Dr. Gigi, and she is a wonderful, wonderful person. So thank you for holding down the comment section, Dr. K.
Well, yeah, but just to share a little bit about my story, I really didn't know anything about diabetes. Growing up in my community, we grew up in the projects, so all we heard was sugar. We didn't make the distinction between the two. But it wasn't until the year 2003, I was working for the Virginia Department of Corrections as a captain / institutional training officer at 2 maximum security prisons, where I was feeling kind of sluggish one day. So I went to the infirmary and I just, was talking to the nurse and I was like, wow, I'm feeling really sluggish. I haven't had a lot of sleep because at the time I was working 2 jobs. Plus I was getting ready to go to school, get my master's.
Mm-hmm.
So, the nurse was like, well, have you ever had your glucose level taken? I'm like, do what? She said, yeah, just let me prick your finger, get a drop of blood. I'm like, okay. When she took my glucose level, she looked at me and she said, can you give me your car keys?
Oh, wow.
And I said, why? Please give me your car keys. So I gave her my car keys. I'm like, why are you going to drive my car? She said, do you know what your glucose level is? I said, ma'am, I don't even know what a glucose level is. It was 748.
Oh my God.
Mm,
She said, you should be dead. You should have stroked out.
mm,
I'm not aware because nobody talked about diabetes. It's not like they taught it in my health class when I was in high school. I had no clue of the impact of diabetes. So she told me if I went to my car, she would call the Virginia State Police on me and have me arrested for driving impaired. So she got another officer, and he took me to the nearest emergency room. They drew some more blood. They checked my A1C, and my A1C was 11.7 on a scale of 12.
mm.
So they was like, yeah, we need to
Can
refer
we
you.
pause just 1 second?
Yes, ma'am.
An A1C is a measure of what your glucose has been running for the past 3 months. It should be less than 5.6. If it's between 5.6 and 6.4, that's pre-diabetes. If it's above 6.4, it's diabetes. We generally like to have it at less than 7. So yours was 11.7?
Yes, ma'am.
That's super high. Please
Yeah.
go on. Please go on.
So I was referred to an endocrinologist who was also a general practitioner. So she became my primary care physician. So immediately they put me on 2 insulin. They put me on a long lasting insulin, and then an insulin that I would take before each meal. So I was taking like 40 cc's of the long lasting insulin and anywhere between 15 to 20 cc's of the fast acting insulin before each meal, as well as being on I believe it was like 2,000 milligrams of metformin.
Yep. So it's units because cc's is a lot.
Oh, okay.
Yeah. So
Well,
it's units.
okay. Thank you.
Sure.
So,
Wow.
so she was monitoring my glucose level. Now, mind you, all she told me was I need to lose weight. That was it. There was no particular diet other than, you just need to be on a diabetic friendly diet. But, I never got any literature. So, I did the best trying to, find this information out on my own. So now we're going to come all the way to 2013. It's April 2013. I go in and I do my normal labs.
Mm-hmm.
And she sits me down and she said, I'm sorry to tell you, but you are at stage 3B chronic kidney disease. She said, you have between 35 to 30% kidney function. Here again, didn't know much about the function of my kidneys, but I was upset because I was like, well, why didn't you tell me when I was at 75% or even at 50%? And she never had an answer. But what she did, she referred me to a nephrologist. The nephrologist, when I first went to the appointment and met him, he told me I need you to stop eating any nut products, any dairy, and chocolate. He said, you're going to eventually go on dialysis, but it can slow down the progress.
Mm.
So again, that progress really didn't slow down that much because we're talking about April of 2013. I eventually started peritoneal dialysis December the 1st, 2013.
Mm.
So in doing peritoneal dialysis, that's a form of dialysis where they take a peritoneal catheter and place it in your underbelly so that I would have to sit at a machine at home and have dialysate, a dialysis fluid, go into my peritoneum cavity, and it would just sit. So that fluid functioned like a kidney. It would pull, they call it sugar water. So it would really just pull all the toxins out. Then after a couple of hours, I would just drain and then put more in to replace it. So I stayed on dialysis until about April of 2017 when I got my kidney transplant. So what's interesting about that is because of the impact, the negative impact that diabetes, type 2 diabetes had on my body, and also using dialysate, which is sugar water, it was really hard to manage. I managed the best that I could, but so now I'm dealing with the contributing factors with that. So when I wake up from my transplant surgery, I'm happy. I'm thinking, yeah, I got a kidney. I'm ready to go. Little do I know that I have a neck catheter, and they told me that my kidney isn't working.
Oh no.
So, but it's no worry, because normally that happens with 33% of the first-time kidney transplant recipients. So they say anywhere between 3 to 10 days, you should be good to go. But in the meantime, you're going to have to do 24 hours of hemodialysis every other day. So I'm like, wow. So 5 days after my transplant, the doctor came in my room and told me that I had a blood clot in my neck.
Oh my
I needed
God.
second surgery. So that didn't go well. I started snatching tubes out. I'm mad. I'm like, you gave me a bad kidney. No, I got to go. And my beautiful wife, she leaned over and she whispered in my ear, baby, I need you to be here with me. Doc, go ahead and schedule the surgery. Okay, I have the surgery. They removed the blood clot. 3 days after the blood clot surgery, I'm hemorrhaging. So now I have to have another surgery. Here again, I repeat that same cycle. I'm snatching IVs and tubes out. I'm like, no. My wife tells me the same thing. I have that surgery. So in between this time, my kidney has not waken up, and I'm still doing 24 hours of dialysis every other day. So 17 days later, after the hemorrhaging surgery, they wanted to do another surgery to create a laparoscopic peritoneal window so that I can drain internally. Mind you, my kidney isn't working. So we have that surgery. So one of the things that I forgot to bring up in this during this journey is because of how out of control my type 2 diabetes was. It caused me to go into stage 5 kidney failure, which means that I wasn't able to urinate for 2.5 years before I got my transplant. So I stayed in the hospital. After 4 surgeries, I stayed in for 33 days. When I got home, I had so many surgeries that they never stitched me closed. So I had to wear a wound vac. And it was the 47th day. Now, I don't know if you are into numbers, but 40 represents trials, tribulations, and probation. 7 represents completion. 47th day, I felt the need to go to the bathroom. 1 drop of urine came down. You would have thought I hit the lottery. I'm breakdancing in the floor. I'm spinning around in the floor. I am happy. Just like a child, a child using the potty for the first time. So gradually after that, my kidney started kicking in, and everything was fine. My kidney function, it was on overdrive. And, my labs was looking good except for my A1C. So one of my favorite transplant coordinators came to me and she said, Mr. G, you're doing good, but you're too fat. I'm going to need you to lose some weight. And I said, ma'am, I've been trying. She said, no worry. And she referred me to the weight loss clinic at my transplant hospital. And I got in that program, and I'll never forget when I talked to the doctor, and the doctor said, "How much weight do you want to lose?" I was like, "Wow, I never had anybody ask me that question." I didn't even know how to respond to that. So I said, "I just want to lose enough weight to where I can manage my health and run after my young grandkids." I have 9 grandkids, so kidney disease, they don't understand kidney disease. They don't understand pop not being able to play with them and chase after them. So so that's what I told the doctor. She said, "Okay." So what they did, they put me on the ketogenic diet. They took me off of all, I'm gonna say it again, all of my medications, my metformin and my 2 insulins. And
Wow.
she said, "Just trust me." And I did. Now, mind you, I've been vegetarian, vegan, Mediterranean, everything. This particular diet allowed me to lose over 75 pounds. And my A1C went from 11.7 to a 5.3.
Wow.
Mm.
Wow.
Yes, ma'am. So one of the things that really helped me, in my advocacy work, I'm very passionate about helping folks not to go through the journey that I went through when it comes to chronic kidney disease, as well as diabetes. But I had the opportunity to work with the American Society of Nephrology on diabetes, kidney disease collaborative task force. So I'm the patient representative on there. And my time on there taught me about SGLT2 inhibitors and GLP-1s. So when I started learning about this and I saw the benefits that it had for heart patients as well as people with chronic kidney disease, it made me think about my family. Both my parents died of congestive heart failure, and they both had um, type 2 diabetes later on in life. My sister died of a massive heart attack, and she was diabetic. My brother had some heart issues, so it was a no-brainer. I went to my weight loss doctor and I said, "Look, you got me from 11.7 to a 5.3. I want to stay here. Can I please get on one of these medications?" And she said, "Well, because you're on a low carb diet, we're going to try you on the GLP-1." And I have been on it since February of 2020. And I think the highest my glucose level has gotten, my A1C, is a 5.8.
Wow.
So
Wow.
I'm here to tell folks, if you ever want to see what a miracle looks like that's not in the Bible, look at me. I'm covered by the Father, but just look at me, because innovations, medical innovations, has come a long way. And if they can save somebody like me, I know that there's a number of folks out there that can be saved.
Wow, Dr. G, that is such powerful testimony, and you have covered so much. And so I just want to come back to it. First of all, thank God for your wife.
Yes,
Thank
yes.
God for what? So she's Mrs. G.
Yes, she's the number one.
Okay.
Under God, but
Well, yes,
she's the boss.
yes.
Yeah, you know how men can be hard headed sometimes.
No, I have no idea. What are you talking about? Please, yes.
Yeah, she kept me straight. My wife never left my side the whole time. Never. And I was on so much medication, I couldn't talk. So she talked for me. Now, the bad part is, if you've ever seen Married with Children, and you know how Al Bundy talks about his high school days. Well, my wife was doing that too, because she used to be a CNA. So
Oh.
every nurse that would come in, "Girl, I remember doing that," and I'm just sitting there like,
But you know what, Dr. G, you bring up such an important point, and that is
Mhm.
having somebody that is your advocate when you cannot speak for yourself. I
Right.
will tell you, as a physician that takes care of people in the hospital and outside of the hospital and clinic, the dynamics change when somebody is there with the patient. People
Yep.
get more attention, they
Yes.
get more time, they get their questions answered. In COVID, it's a little bit more challenging, but I
Mhm.
think as things kind of get back to normal, that is such a powerful lesson.
Yeah.
You also talked about, because you kind of glossed over it a little bit, but I think that this is very important. How your initial physician, I don't know if she missed it or minimized the kidney part of your diabetes, but there are medicines that we give as standard of care to prevent diabetes from affecting your kidney. And that's why your advocacy is so important. So when somebody's diagnosed with diabetes, they really should be asking about, well, how does that affect my of course, my glucose, and what's my A1C? Is there evidence of there being leaking of protein in my urine? Because that's the very first thing that happens, and it's a small amount. So they have to get a special test called microalbumin. What's the condition of my eyes? What's the condition of my heart? How is my circulation? Kind of going through that checklist. And
Mhm.
here's the thing, if you're not getting satisfaction, whether it's from a general internist, general practitioner, uh, you know, primary care provider, you should see a diabetologist, somebody who specializes in diabetes, or an endocrinologist, because guess what? Studies show that for people who, like yourselves, who had difficult to control diabetes, their outcomes improve when they see a specialist.
Mhm.
Yeah. I certainly agree.
Yeah. Can you talk a little bit more about that first experience? What was her explanation about sort of not being attentive to the kidney? I mean, I'm not saying this to be punitive. Was it something just that she was not aware of, or what happened there? Do we know?
I want to say it was cultural competency or lack thereof of it. And again, this is why I really love what I do as an advocate, and I really respect the people who I advocate with, because we're very passionate about fighting against injustices, lack of health literacy.
Mhm.
As an example, um, I felt betrayed because
Mhm.
the diagnosis never changed.
Say
It
it.
was like, I need you to lose weight. But then once I got my kidney, and once I started going to the weight loss clinic, my transplant nephrologist sat me down. He said, look, how can you lose weight when insulin helps you store fat?
Exactly.
And
Mhm.
I'm like, I don't know. I don't know. And nobody taught us that. I know now. And we're able to go into the community. We're able to go into communities that folks don't want to go in. Let me just preface that.
Of
Right.
course.
Say
We're
that.
able to go into underserved, undervalued, disenfranchised communities of color
Hmm.
and speak to people's pain, because we come in as wounded warriors. We come in afflicted, and we meet their needs.
Right.
And a lot of times people think, if you don't look like you're hurting, or if you don't look like you're suffering, you're okay. And you may not know what questions to ask. So you're right. It's always good to have a support person, because when I would forget to ask a question, my wife is very inquisitive. So it was nothing for her to say, well, doc, he didn't ask that, but I want to know this, this, and this. And I'm sitting there like, wow, I forgot about that, because brain fog is real.
Absolutely.
Yes, it is real.
Absolutely. And you talked about your high blood pressure. One thing that a lot of people, including physicians, by the way, don't know is that when you have diabetes, especially if it's not well controlled, It may take 4 blood pressure medications to bring your blood pressure down. And
Doc,
of course, yeah, so
Doc,
the
try 10.
right, well,
Doc,
see, that's for
Doc,
you.
I went through the whole gamut. My blood pressure averaged 210 over 190.
Oh my God.
I was on everything at
Well,
one time.
that's because you developed kidney disease. I'm
Yeah.
talking about not having kidney disease
Okay.
before that part. It takes 4 medicines,
Yeah.
and sometimes people will look at the glucose and handle that, but not handle the high blood pressure. All of that needs to be handled, right? And of course, when you do develop kidney disease, it can be almost impossible to control the blood pressure. And you talked about it's not just cultural competency. Let's call it what it is. It's medical apartheid. Let's be very clear about it.
Okay.
Because this is, well, because
Yeah,
this is
no, you're right.
why,
Yes.
no,
Yes,
but
you're right.
right? I mean, there are maybe 2 or 3 standards if we put class in there as well. But
Mhm.
so what is important is that one tries to choose somebody that is well trained, and studies show that if Black people get Black physicians or people of color, their outcomes are better. That's why workforce is so very important. But
Right.
going back to you, because I don't think a lot of people know about peritoneal dialysis versus hemodialysis. Actually, this is something that interests me because peritoneal dialysis is often not offered to Black folks. And yet it is something that can make it a lot easier to be on dialysis because you could do it at home and you don't need to take time off work. So can you tell us about that a little bit more?
Um, Actually, it was record highly. I think I was steered in that direction because my nephrologist told me I was a good candidate. He told me that I was very cognitive at the time. I seemed like a very um independent type of patient, and that would
Mhm.
adhere to the rules and regulations. So he really pushed me in that particular area. Now, there was a point where I had to end up doing in-center hemodialysis, and that was only for maybe a total of 6 months. But I really love PD. The only thing that's interesting is trying to travel with all of those cases. You have I think my weight restriction was like I couldn't lift no more than 25 pounds, but my machine weighed 35 pounds.
Mm,
A case of fluid was like 30 pounds.
mhm.
And if you are lifting, you stand a chance of getting a hernia, which I ended up having to have hernia surgery. So,
Mhm,
but
mhm.
it's always good to be able to dialyze at home. But from what I'm told, the reason a lot of people don't push peritoneal dialysis or home dialysis is because at least 90% of nephrology students come out not knowing about home therapies
Yes, that's right.
in this country
That's right.
compared to Canada.
That's exactly right.
Yeah, yeah, compared to Canada, everybody knows about it. So,
Yep. Yep.
but CMS is really making this big push for home therapy. So,
Yeah, that's the CMS is the Center of Medicaid and Medicare Services. And yeah, actually, I work with somebody who is from Canada. And actually, the technology for being able to do home dialysis, as you're describing, is rapidly changing so that it doesn't have to. I mean, when I was a student, it used to fill up this whole room. Now it's gotten smaller and smaller, and they're trying to make it more portables, like there are units. I don't know if you probably use them because even that has changed in the last couple of years. They're like this big and you can sleep. You can sleep. You put it on your bedside and you can sleep while the dialysate is going in. It's really changed quite a bit.
yes.
But yeah, a lot of people don't know about it. And so I would say to anybody that's listening, if you look like you're going to need some kind of dialysis, or they call it renal replacement therapy is another term for it, go to somebody who knows what they're doing so that you can ask about peritoneal dialysis, because with hemodialysis, since they actually wash the blood, there tends to be more problems with feeling more tired. I mean, well, why don't you tell us, Dr. G? You've had both. How did you feel with the peritoneal versus the hemodialysis? Did you have a difference in how you felt?
When I did peritoneal dialysis, I did have more energy. What really got me was the fluid and having it in for so long, and because it's pulling away waste, I could feel my, I could feel my stomach bulging.
Mm-hmm.
Hemodialysis, I'll never forget the first time I did hemodialysis. I thought I could handle it. I'll never forget, I did my very first exchange. I drove all the way home. I got out the car, I'm like, stick the key in the door. And my wife found me there when she got home from work, and she works in DC.
Oh my
Half of my
God.
body, my upper torso was in my living room. My bottom torso was in the garage. I had just passed out and fell asleep. So it literally would drain me. So, going in 3 days a week, that off day I spent sleeping the entire day, just getting up just to go, into in-center. So it did take a toll on my body. So I really preferred peritoneal dialysis.
Mm-hmm. And tell us a bit more about your kidney transplant. How long, bless you, Mr. D.
Thank you.
How long were you on the waiting list?
I was only on the waiting list 14 months. I actually received my first offer. I got on the wait list February 2016. I received my first offer May the 20th, 2016. Because of my size at the time, they wanted to offer me 2 kidneys to function as one. Again, I don't know anything about kidney organs or how the OPOs, the organ procurement organizations work. So I'm thinking I'm special. Wow, I'm gonna walk around with 4 kidneys. I'm like, wow. Come to find out, go to my transplant center, meet the surgical team. 20 minutes before surgery, they said that one of the kidneys work, the other one doesn't. So we're not going to do surgery right now. But it wasn't until maybe 2 years ago at a workshop when I asked a person from the OPO, why did they offer me 2 kidneys? They explained to me that the kidney had made its cycle. It had gone through the list of 5 people, the first 5 that was on the list, and before they discarded it, they just wanted to make a last offer. So I was grateful that they kind of caught that issue, because I would have hated to get those kidneys and then the one would have rejected, and then I would, still be in the midst of waiting for a kidney.
Let me ask you a quick question here. And if you're just joining us, we're talking to Dr. Patrick G about his journey from diabetes to chronic kidney disease and multiple surgeries and 2 types of dialysis and everything he has gone through. And my question is, what I'm interested about is mentally, how were you handling? Because I know at one point you said you were ready to give up. There had to be multiple points along this journey. I think I've heard at least 4 or 5 different surgeries along this path, and blood clots, and we've got to do this and we've got to do that, and this is not working, and there's got to be frustration, there's got to be anger, there's got to be disappointment, there's got to be just, you know what, I'm tired. Talk to me what your mental processes was going through this entire from 2013 to now.
I did not know until probably a couple of months ago when a young lady I consider a daughter in advocacy sent me a flyer asking me if why don't we talk about medical trauma?
Mm.
And when I looked at the flyer, I was like, wow, I went through all of that. I should have some form of PTSD. I mean,
Mhm.
because, you know, mm, if I was to send both of you a picture of when I came home after they um, removed the wound vac, I know I showed it in my church when I preached my trial sermon. And my pastor had to pull me to the side and talk to me. He was like, "Wow, that's too traumatic." But um, it never dawned on me that every time I would go back for an appointment, I understood white coat syndrome. My blood pressure would go through the roof while I'm at
Mhm.
home. It's normal 120 over 80, but soon as I hit the parking lot, it's like 167 over 85. And,
Mhm.
I'm like, wow, I'm feeling all right. It was rough because I'm laying in the bed. I have a kidney. I'm thinking about my peers. I'm thinking like, wow, nobody told me about a story like this.
Mhm.
And I'm looking at my wife, and though my wife is there, I know my wife is going through what I'm going through. So I don't want to put any more on her.
Right.
So I was very lucky to have my senior pastor, other pastors, elders from the church to minister to me.
Mm.
But in those moments where I was by myself, it was devastating
Mm.
just to keep having those flashbacks and then to keep seeing this picture of my stomach wide open
Mm.
after all of these different surgeries. And then, my kidney isn't working. And, I start questioning, I even asked God, what in the world, why? I prayed for a working kidney.
Mhm.
What was revealed to me is that we serve a specific God.
Mm. Yeah.
And I didn't ask for the kidney to work as soon as I got it. So I had to go, as my pastor told me, I had to respect the process. It's like the delay does not mean denial. And I
Right.
had to ride this thing out. But there's a number of people, even right now, when they're told that they have to go on dialysis, the impact of sitting in a chair and looking over to you and understanding that that machine is keeping you living.
Mm.
There are marriages that are broken where people say, I don't want to be with somebody like you because your sex drive is going to be low, or you just don't have that desire, or your skin is going to change, or whatever the case. Vows are broken. Um, it's a very lonely feeling. And here again, it wasn't until recently where I had a breakthrough. And earlier this year, my church did a grieving well workshop, and I'm sitting
Mm.
there, and I did not know that there were 18 different types of grief, and I think I hit every last one of them.
Mm.
And I'm sitting there as a grown man, sitting there beside my wife, bawling
Mm.
because I had all this hurt, but nobody said, "Hey, you went through all these different surgeries. Do you want to talk to a therapist? You want to talk to somebody? You need to talk to a counselor?" Nobody. And I think that's one of the greatest social determinants in healthcare, especially now during COVID. I mean,
Yeah.
even thinking about that, I'm a COVID survivor. I I was a COVID long hauler for 291 days.
Oh my goodness.
I mean, it was atrocious. But what was even worse is that my wife and I both had it at the same time, and she ended up being in the hospital for 6 days. And to only be able to FaceTime her, to only be able to talk to her through the phone, and my wife is laying there suffering. And again, this took me back to when I was in the hospital.
Mm-hmm.
And it was like, wow. So, even though I'm 4.5 years into my kidney transplant, I really didn't find any closure um, to my medical trauma until this past summer. And I would advocate for anybody, it's good to try to be strong, but that faking it until you make it, some of us don't make it. And
Amen.
some of us can't fake it. So if you have the opportunity to get help, to be mentored by somebody that has gone through it, I certainly am telling you right now to do that, because it's rough. It is certainly rough. And thank you for asking me that question, because when you talk about behavioral health and you look, you think about wearing a mask, and in the political climate that we're living in and the violence that's going on, and then looking at the people that can't get adequate health care because of COVID, and clinics and things closing down. We all need somebody to talk to. So yeah, that was
Dr.
a very
G, you
promotional.
really have been speaking the truth, because um, I had not as a dramatic an experience, but I was in the ICU for 8 days and had 30 hours of surgery. And there was no recognition by the medical team, as much as they were great in terms of taking care of me medically, about what the emotional or psychological toll was. I think the way that people are trained here in the United States, it's very sort of unidimensional. Okay, your kidney is functioning, goodbye. Oh, the wound is healing, goodbye. But we're human beings, we're not body parts. And so, especially as a man, for you to share what you have shared, and also a very strong man, to tell us about the need, to talk to a therapist or to be in some kind of support group. I mean, I think that that is just golden, because so many people feel such shame. And of course, you in your, ministering role and, as a pastor, this probably better than any of us, but that is so powerful. Your testimony is so powerful. So I thank you for sharing, because you have hit on so many things that really don't make it to the light of day,
Right.
and yet can really be hurtful and can actually delay and hamper recovery. And that people actually suffer in silence. And the interesting thing I've found is that the way that men and women deal with grief or sadness is different. And sometimes, not you, obviously, because you talk it out with your wife, but sometimes men can manifest it more in anger. And when you're in a medically vulnerable situation or health wise, and then you're also lashing out at a time when you need that support, that can be very confusing for family members. I'm sure you've seen that in your practice.
Oh yeah.
Yeah. I think ultimately, and thank you for sharing. I think ultimately we have to recognize that we get a summary, right? And so the summary is that Black people aren't adherent to medical treatment and to follow up, right? But what they don't know is all of the trauma that you had to endure along this way, and and you're in there and you're on medications, you can't talk, and you're on the brink of giving up and letting go of the rope, and your wife is talk all of these things, and they're just straight, well, he doesn't, and they just summarize, well, and it's not that way. And when we talk about Black people in general and say, oh, we don't really connect to the healthcare services, then realize what we have to deal with in terms of microaggressions, social determinants of health. All of these things are put into how we interact with healthcare. And healthcare just summarizes where Black people don't engage. Well, let's talk about why. And when we get to the why, we have to, when we start pulling back all those layers, that why becomes really complex. You know, my mother used to have a statement. She says, still waters run deep. Okay.
Mm-hmm.
So when you just look at the surface, it looks like it's still. That's some still water, but you got to check because it's got some depth to it. And so we've got to recognize we got to get to the depth of it and find out what's really going on and really help people and get on the healthcare side. We've got to get medical providers to think about, hey, they might need some mental health services when we're talking about the amount of surgeries, what you had to endure just to stay alive, just to be healthy and stay alive, what you had to go through. There might be some mental anguish, something that you need to work through as a result of everything that you had to go through. And so thank you so much for sharing. I think it's important for our audience to hear that and recognize that, hey, it's not just them that are going through it, it's all of us.
Yeah.
Mr. Ellis, this is such a powerful hour that we've spent. I can't believe it's already been an hour, almost an hour. But here is a suggestion, Dr. G, because what we didn't get a chance to really talk about, which I think is so important, is the transplant aspect. And I have two colleagues, Dr. Keith Mellinson, who does the transplants where I'm at, which is George Washington in DC, and he does them like 19 people and so forth. He happens to be African American himself, and so he can also speak about some of these barriers, you know, the medical apartheid system that we've talked about. So I'm wondering if we can't have a part two, Mr. Ellis, and bring Dr. G back, because this is so powerful, really powerful.
I do think we need to talk about that transplant situation because when Dr. G and I talked earlier before the show, you know, I shared that my father's on dialysis right now. And he was like, oh, does he need a transplant? Like, so he was already like, what, does he need a transplant? We can get him a kidney if he needs one. And so it's really, really important for our audience, for everybody, especially the audience that we serve, to recognize that while there might be some barriers, those barriers can be removed and advocates can really help. And then programs like this of helping people understand what they should be doing, because I didn't know anything about perinatal
Peritoneal dialysis.
like I'm mixing it with child stuff. So peritoneal dialysis, I had no idea about that, right? And how long have we been doing this program and all these different things? And so there's so much out there in the medical community that we don't know about, and that's why we do these programs. So I think a part two is absolutely necessary. And I would be remiss if I didn't give Dr. K, Special K, a shout out for holding down the comment section. She has been so gracious and wonderful in terms of answering questions out there, being very patient. Shout out to Nicole and Christina for all of your comments, because you have really added to this discussion, even in the comment section. So when people go back and again, they say, y'all have been so wonderful in keeping that. So keep me out of the comment section. Dr. K took it. I was like, cool. So I can engage in this discussion, because sometimes
and Dr. K is Dr. Kendra Outler, and she'll put her site in the chat.
Please, Dr. K.
Yeah, her not-for-profit site, because she's just doing incredible work. So we want to give her a shout out and make sure that people know about her website as well. But this was terrific. Really, thank you. It was such a deep and wonderful discussion. And when can we see each other in real life? I'm so sick of these Zooms, because I would want to hug you, Dr. G. You know I'm a hugger, right?
Look, I'm just an hour and a half away from GW. All you got to do is just let me know when you're ready for lunch. I hit the road.
Okay, all right. Well, and your wife, because I want to see.
And look, and she works in DC.
Okay,
yeah, she works in DC. So yeah, you know.
Okay.
Well, yeah, y'all can make that happen. And Dr. Gigi, we've known each other for over a year now. I have never seen each other in person. And so, and there was a time where I would go to DC on a regular basis. So I need to make sure, make a special trip just to come see you and hang out there. And everybody at the Rodham Institute, Christina, and everybody there in your office that I've had so much communication with, but not seen in person. And so definitely need to make that trip up there. So I just want to say everybody that's been in the chat room, that's not been in the chat room, just been watching. I would thank you for staying with us for this program. Thank you particularly to our guest, Dr. G. You have been wonderful. You've been everything that they told me you were going to be and more. And so I'm sad, so we're going to get a second showing because we got to talk about the transplant part, right? We've talked about that part, and we talked about mental health. We got to talk.
Can I also add this one caveat and something that's extremely important, Mr. Dean and Dr. Gigi? Can we please talk about rare genetic kidney disease like APO1? Because a lot of Black people in the community do not know the impact that APO1 can have on them. So if we do transplant, we'll just ask if we can do APO1. I got a crew ready for you.
Well, when we talk offline, we can think about who else to bring because
yes, ma'am.
Kidney, we're in Washington, D.C. We have the highest per capita in the country of end-stage kidney disease.
Yes,
so
ma'am.
this is an issue that affects people because of work, as you mentioned, their family, their love life. It has so many effects. So thank you. Yes, we'll make sure to bring on whomever you think is appropriate to bring on.
Yes, ma'am. Thank you.
Medical, and you touched on it all night, Dr. G. Medical literacy. It is very, very important. And that's what you're talking about. Understanding when we go into the doctor's office, just having a general understanding is life-saving. It is life-changing. And so whatever we can do here at Black Doctor, go to the website. There's a whole channel dedicated to kidney issues. Please, and we're going to continue to do programs like this. Dr. Gigi, thank you so much for allowing us to talk about this on your program. This has been a wonderful. So we look forward to part 2 on that whole transplant process, and we're going to talk with Dr. G, and we'll talk about APO1 and whatever, just to really whatever how many programs this takes. We're going to get this information out to people so we can save some lives.
Thank you.
Thank you. Good night.
Thank you for joining us, and we'll see y'all next time.
Good night.
Bye-bye.